Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I am your co-host, Dr. Kathy Leeper. I've been a breastfeeding medicine specialist since 2001, and I'm currently practicing in Nebraska and Kansas.
This podcast is produced and edited by the Milk Mob and is co-sponsored by the Academy of Breastfeeding Medicine. Are you ready to go? Hi, Kathy. How are you?
Hey, I'm good. How are you?
Good. So today I'm going to talk about the American Academy of Pediatric update on infant sleep and breastfeeding. And after I do that, you're going to talk about the Academy of Breastfeeding Medicine Clinical Protocol number 3 on non-pharmacological management of procedure-related pain of breastfeeding infants, the updated ABM protocol. So first, I'll talk about AAP.
Sounds good.
The American Academy of Pediatrics recently updated their policy statement on sudden infant death and other sleep-related infant deaths, and this was done by the Task Force on Sudden Infant Death Syndrome. This was just published in 2016. And the article starts out with some demographics stating that approximately 3,500 infants die every year in the United States from sleep-related infant deaths. And just as an example, there was just an article in the Wisconsin State Journal just this weekend that a young mother in Wisconsin was recently found guilty of suffocating her 3-month-old. She apparently was, it's very sad. She was intoxicated, and she fell asleep on top of her infant in a relatively makeshift bed. And so it's just a horrible situation. So it does happen. Mm-hmm. According to their article, sleep-related infant deaths initially declined right after the Back to Sleep campaign in the early 90s, but in reality, the number of sleep-related deaths hasn't really declined in the most recent years. Mm-hmm. So my guess is that most, if not all, of our listeners know that the American Academy of Pediatrics recommends that infants should be put on their backs to sleep on a firm mattress and without any soft bedding or toys. And a lot of the current statements recommendations are in the 2011 American Academy of Pediatrics statement on sudden infant death. So I'm not going to go over the entire statement. There's not a lot of there aren't many new things, but there are a few that I think are interesting. Mm-hmm. The 2011 statement covered the importance of avoiding cigarette smoke, alcohol, and illicit drug exposure, that was the first time that it endorsed breastfeeding as a preventative measure, which was very exciting, and that and that continued in 2016. So what's new in this statement is, first of all, they clarified that skin to skin is important, and skin to skin was not mentioned in 2011. And I think that they're trying to avoid stating that all infants should be put supine when sleeping, because sometimes babies are sleeping when they're skin to skin, which is kind of a prone position depending on the position of the parent. Skin to skin is beneficial. In one of their other policy statements that was published in September, they discuss the safety recommendations with skin to skin. So there are some issues with skin to skin to make sure that the infant is safe when prone in terms of like airway. Mm-hmm. But in the meantime, they state that when parents need to put the baby down after having the baby skin to skin, the baby should be put down supine on a firm surface in accordance with their other recommendations, such as avoiding overdressing, overheating, and in an environment that's free of other objects that the infant can choke on or become strangulated from. Mm-hmm. So in 2011, room sharing was in the 2011 statement. They did recommend room sharing, but this statement is a little bit different because the duration of room sharing wasn't really clear in the last statement. And in this statement, they make it clear that they recommend room sharing for at least 6 months and even up to a year. And they emphasize that room sharing has definitely been shown to reduce the rate of sudden unexpected infant deaths, probably because there's less risk of danger, strangulation, remembering that things were, thrown into the crib by accident, and so they can see them and take them out, things like that.
Mhm.
In 2011, they advised against using any kind of sidecar, those like newer cribs that you can attach to a bed.
Right.
And people, I find that my patients like them because they can, they can reach the babies, they can put a hand on the baby and feel really close to the baby without worrying that they're going to roll over on the baby. And in 2011 they actually recommended against them because there wasn't really any information about them at all. And in the updated statement, they now say that the Consumer Product Safety Commission has safety standards for these. And so they recommend that it's okay to use a sidecar that meets the commission's standards. But they do state that there's really no data on the risk of unexpected deaths with those things, or whether or not they're protective of sudden infant death.
Not yet.
What is that?
We don't have any data. We don't have data yet.
Not yet. Yeah, eventually more people use them. So the 2011 statement emphasized firm mattresses, but it didn't mention anything about memory foam. But now the statement specifically says to not put babies down on memory foam or those mattress toppers. And they also mentioned that some companies advertise these mattresses that are breathable in case the baby does end up prone. But the American Academy of Pediatrics states that they can't endorse these because there's no data on them. And then finally, the biggest change, I think, in the statement is the whole issue about nursing or feeding in the middle of the night.
Yes.
And in 2011, they said it was okay to nurse the baby in bed as long as the parent doesn't fall asleep while nursing or feeding the baby in bed. And then when the baby's done feeding, to go ahead and put the baby back in the crib. But you and I both know that that's not really what happens, right? Because especially if mom's breastfeeding, she's going to fall asleep. So it emphasized in 2011 that feeding on a couch or recliner in the middle of the night was not safe due to the risk of falling asleep during feeding. And, we know that those are very unsafe surfaces to be on. So in the 2016 statement, they acknowledge that adults do fall asleep when feeding infants at night. So it's really better to nurse or feed the baby actually in bed than going to a recliner or going to the couch in the middle of the night, because if a parent feels like they're likely to fall asleep while feeding, then it's much better to be on that firm surface. And then if the parent falls asleep with the baby in the bed, when the parent wakes up, to then put the baby back into the crib or the bassinet, basically take the baby out of the bed at that point.
Right.
So there still, of course, is the concern about the parent's bed, which they mentioned throughout the policy, in terms of like if one parent is intoxicated or medicated in some way or a very heavy sleeper, or if there's another child in the bed, or if the bed is unsafe in some way, such as having pillows or the risk of the baby falling between the mattress and the wall or the mattress and the headboard, all that kind of stuff that we are aware of. So those are basically the updates in the 2016 SIDS and other sleep-related infant death report by the American Academy of Pediatrics. Do you think they left anything out?
Well, I wish they would have gone into more detail about how to make an adult bed surface as safe as it could be.
Yeah, I agree. I think that the American Academy, the Academy of Breastfeeding Medicine statement is pretty good about that. It's pretty specific about how to make the bed safer.
Right.
I want to mention, too, that La Leche League has its, I guess I wouldn't really call it a campaign, but they came up with a really nice handout for families regarding safer bed sharing, because even though the American Academy of Pediatrics says, don't sleep with the baby in the bed, we know that people do anyway. And there's pretty good evidence that if these 7 rules are followed by the La Leche League, so they call it the Safe Sleep 7 rules, that basically breastfeeding infants should be safe. So the rules are that if a mother is a non-smoker, she's sober, she's breastfeeding, and the baby is healthy on his or her back and lightly dressed and not swaddled, and they share a safe surface, like a firm surface without, all kinds of stuff around, then the baby's risk of sudden infant death is no greater than in a crib, and any breathing hazards have been hugely reduced. So, I feel that there's good evidence for 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 that statement, and I think that those are, some rules that we can share with families who are, if they're willing to talk about co-sleeping. I think those are fair rules to share with them. Unfortunately, I wish that, I wish that American Academy of Pediatrics would address that as well. The
Right.
issues. They do say that there's no question that breastfeeding is protective,
Mhm.
but they still do kind of state that just a perfectly healthy breastfeeding baby is at higher risk for sudden infant death if mom is nursing in bed,
Yeah.
despite those issues. So there's some controversy there.
There is, and like you say, the important part is having the conversation
Right,
uh,
right,
directly with the parents.
right. I think that some of the consequences of the last AAP statement are that parents have become very, very freaked out about having their babies in bed to the point where they're just so anxious because they find that they can't really sleep because the baby's up often. The baby's happiest if the baby is
Mm.
snuggled or skin to skin, and they absolutely will not bring this baby into bed, and
Mhm.
then they're worried about the couch and the sofa. And I feel that there's just these parents are just, are
Walking the floors in the middle of
walking
the
the
night.
floor. Yeah, they're
Mhm.
beside themselves. And so I actually find, just for their mental health, that I oftentimes will say, why don't you just take your baby in bed? And I would say that common response is, I just can't do that. I just absolutely cannot do
Mhm.
it. So I think we still don't have an answer for those families on how to help them get some sleep and their babies to get some sleep too.
Right. And that extends into the hospital setting, I mean,
Yes,
it's not as long a period of time, but it's a very vulnerable, sleep-deprived period of time, and I look forward to the day when we can have a way that mom and baby can both rest soundly, safely.
right, right. And I think that one of our hospitals in Madison is looking at having those sidecars in the
Great.
hospital. Yeah, I think that would, and the other thing about having the bassinets in the hospital is that if a mother had a C-section or she's sore or not feeling stable, to lift the baby out of that
Yeah, it's
box,
a long
and then
ways away.
it's a long ways
Mhm.
away, and then actually having to lift the baby and bring it over. There have been babies that have fallen
Mhm.
because of moms not having a firm grip. And so having it really attached to the bed in its own little area makes a lot more sense.
Yes, I think so.
Yeah. Okay. So you're going to talk about the Academy of Breastfeeding Medicine protocol number
Number
23.
23.
Yeah.
Yes. Called Non-Pharmacological Pain Management of Procedure-Related Pain in the Breastfeeding Infant. It's newly revised and recently published in our journal. Sarah Reed-Strempton, an anesthesiologist in Washington, D.C., and Larry Gray, a pediatrician in Chicago, wrote the revision.
Great.
The purpose of this protocol is to provide healthcare professionals with evidence-based guidelines on how to incorporate non-pharmacological or behavioral interventions to relieve procedure-induced pain in the breastfeeding infant. So we know that we do routinely subject newborns to painful procedures like vitamin K and vaccinations and heel sticks. And so this protocol is about what we can do to decrease the amount of pain that they're experiencing. In term newborns, the first choice for decreasing pain in babies is who are having a single painful procedure like a heel stick is breastfeeding during the procedure. And it's important to know that it's not helpful to put a baby to the breast before a procedure, then take them off the breast to do the procedure, because it's been shown they do not respond any better than those babies who didn't get to go to the breast at all. So they must be at the breast during the entire procedure to receive the full benefit. If the baby refuses to latch on at the time they're to have a procedure, then skin-to-skin contact with mom or somebody else, if mom's not around, can be comforting. And not surprisingly, if you combine skin-to-skin with direct breastfeeding, it's been shown to provide superior pain relief over skin-to-skin alone or sucrose alone.
Yeah, so I had a question about that because
Mm-hmm.
when I think, so that means that if moms do skin to skin and breastfeed, I kind of think of that as being funny because, okay, does that mean that mom is taking off her shirt and bra and the baby's being
Right.
stripped down, which I think
Mm-hmm.
that a lot of mothers, like in my office, are not going to be super comfortable having the phlebotomist come in to do the bra while they're like,
You'd have to be prepared for that, I suppose, with a gown that
yeah.
opens in the front and all of that.
Yeah. Plus, they're there for the baby and not for themselves, and so, they
Right.
may. Yeah. So that's kind of interesting. So,
Yeah.
yeah,
There would be some logistics to hammer out, but
yeah,
I suppose once moms understood that it was helping their kid out, they might be willing to do that.
yeah. I think
So,
it's been more the staff, the office.
yes, and it would be more work to let the mom disrobe and such
Right.
halfway. So far we have direct breastfeeding, skin to skin with or without direct breastfeeding as both effective strategies to deal with pain relief. Next is warmth, that has been shown to have an analgesic effect of its own, which a baby would be getting during skin to skin, but if that's not possible, a radiant warmer could be used. And the smell of human milk alone has been shown to reduce pain in several studies. So if a baby were refusing to take the milk for some reason, just smelling it can be helpful.
Yeah, that's interesting.
Yeah. Sucrose, as I think everyone knows, has been shown to be an effective analgesic for newborns and young babies for lots of minor procedures like heel sticks and venipuncture and injections, but not for lengthier, more invasive ones like circumcision or even bladder catheterization if baby's over 30 days of age. And sucrose plus non-nutritive sucking is even more soothing than the sucrose by itself. In fact, sucrose plus non-nutritive sucking gives similar relief to direct breastfeeding. This is done by dipping a pacifier or a finger in 24% sucrose solution and then having the baby suck on it, starting about 2 minutes before and then during the procedure. If sucking is not an option for some reason, then the sucrose solution 0.5 to 2 mLs can be given directly or orally with a syringe 2 minutes prior to the procedure. And it's important to note that 24% sucrose placed directly into the stomach does not have this analgesic effect. It has to be placed in the mouth.
Mm-hmm.
So sucrose and glucose both appear to be equally effective, but sucrose has been shown in one study to work better than breast milk when it's not obtained straight from the breast. So if the baby will not latch for a procedure, then sucrose given while the baby is skin to skin, according to this one study, might be a better analgesic than express breast milk while skin to skin.
Mm-hmm.
But we certainly need some more studies to verify that.
Mm-hmm.
Lastly, sucking alone on a pacifier or a finger is somewhat soothing by itself, so it's better than nothing if breastfeeding, human milk, skin to skin, sucrose and glucose are all not available at the moment. Sucking is better than nothing.
Mm-hmm.
For preterm babies, there's less research on this topic, and the ABM protocol makes recommendations for babies at least 27 weeks gestation, just admitting we don't have enough data on earlier preemies to say much. So for babies at least 27 weeks, So for babies at least 27 weeks gestation, recommendations are similar to the term newborns in that skin to skin or smelling human milk or a pacifier dipped in sucrose or water to suck on or sucrose given orally all can be effective strategies. But the dose of sucrose is smaller. It's 0.1 to 0.4 mLs of the 24% solution. And studies on preemies have been shown to be most effective when given 2 minutes before immediately before and 2 minutes after a heel stick specifically as the procedure.
Mhm. Yeah. I think this was such a good protocol. It was really great. And then I saw that in the references, there actually is a new update that came from the AAP as well, from the American Academy of Pediatrics, from their Committee on Fetus and Newborn and Section on Anesthesiology and Pain Medicine, called Prevention and Management of Procedural Pain in the Neonate and Update. So that was just super recent. I guess it was in February. And they also, strongly indicate that breastfeeding is a very important way to decrease pain. And they emphasize that all people, all providers like physicians and family medicine physicians who work with infants should have some means for some plan to deal with pain when they're doing procedures. Which I personally think in our whole medical system we don't have an expected organized approach to this for immunizations and heel sticks.
That's true.
Yeah, and I began thinking, like, why is that? Why don't we do that? Years ago, they used to say that premature infants didn't feel pain, so they would just do surgeries on them without any. And I know, isn't that freaky? But so after reading this protocol and reading the AAP protocol or policy statement that just came out too, I feel like I want to take a really organized approach to at least my office and make sure that we come up with a strategy. But the one thing I would say is that my patients, when I say to them, you could breastfeed while we give your baby immunizations, they worry about that because they say that they don't want the baby to associate breastfeeding with pain. And I looked at, one of the reasons I pulled this AAP statement is to see if there was any mention of that. And I didn't see that.
Well, gosh, it would seem when the baby goes to the breast hundreds of times and has a positive experience that the reason it's helpful, or one of the reasons it's helpful, is that it is such a positive experience. So having one negative stick during that positive experience amidst hundreds of positive experiences, you wouldn't think that it would.
Yeah, I agree. I think parents are really worried about that. But when you think about it, like when I examine a 15-month-old or an 18-month-old, they won't sit on the table by themselves. They worry, and so as soon as they sit on the parent's lap, then suddenly they're happy and they're more willing to let me examine them. And I guess it's kind of the same thing.
A similar thing, yeah.
Yeah.
They're in a safe place.
Right.
Comfortable happening.
Right. I was one of the things I thought also that was interesting is that this early pain that we're not treating may end up having significant consequences for infants when they're older, that they may have a heightened sensitivity to pain in the future. And and I don't think that we really acknowledge that too much. But when I look at my own patients, some of them are very well adjusted when they're older, and they do fine, and they come in and say, okay, I'll have a shot, whatever. But I find that when they're between 6 months and 2 years, after getting shots at 2 and 4 months, at 6 months, they already sort of freak out when they are laid on the table just for an exam, because they feel, you can just tell that they know that they're feeling very vulnerable and worried. Whereas I have a number of patients in my practice that don't immunize, and those babies are just the calmest, happiest babies ever in the office because they've never experienced that kind of pain.
Right.
So I guess, they really, it's always amazing to me by 6 months how they have figured that out already.
Yeah, they're smart.
They're smart, yeah. So that all sounds good. Anything else to add?
Yeah. I was going to add that in the premature set, there's a study about babies between 32 and 37 weeks showing human milk was just as effective as sucrose. So it's counteracting the prior statement that we have one little study that says sucrose is more effective than expressed milk. So stay tuned. They're contradicting each other in those two slightly different age groups.
Yeah, and these are probably not humongous studies either,
No, they're not.
Yeah.
They're not.
Right.
They're a small number.
Right.
And unfortunately, there's even less information when you get over 1 month of age in the term baby set. Between 1 month and a year, there's not much in the way of research except in the sucrose, that it continues to be effective for minor procedures up to a year. And the protocol goes on to suggest that even though we don't currently have any data proving that breastfeeding is helpful for kids over a month of age, it would seem there is potential benefit and certainly no risk if breastfeeding mothers would like to try breastfeeding during immunizations or heel sticks.
Right. That makes a lot of sense. I think we really need to be working on that. And I think also it's like one of those things where we can tell parents when we talk about reasons to breastfeed, we can say, you know what, it's a great way to comfort kids when they're undergoing pain. And for sure, I talk about this when, when infants are, when they're toddlers between 1 and 2.
Yeah, and they fall down.
Yeah, they fall down. They're sick. They have nausea. They have a fever. What a great way to nurture a toddler, Yeah.
Absolutely.
Yeah, it's a back pocket technique. All right. Stuff. Yeah, well, it's good talking to you, Kathy, and we'll stay in touch and talk to you soon.
All right. Thanks a lot.
Yeah, bye.
Bye-bye.
For questions regarding this podcast, contact us through themilkmob.org. We have other educational projects going on there, such as the Clinical Question of the Week and our Outpatient Breastfeeding Champion programs. If you want to see what we look like, check out our Facebook page, where you can also share comments and questions with your co-listeners. To learn more about the Academy of Breastfeeding Medicine, please visit www.bfmed.org. Thanks for listening. We'll be back with you in a few weeks.